would like to welcome on stage Dr. Rajashekhar Perumal, Dr. H. Ramesh, Dr. Shailesh Srigandan, Dr. Senthil Kumar.
So, can you hear me?
Yes, sir.
So, shall I go on straight away? Without much ado, as they say?
Yes, sir.
Okay. So, I'm going to share my screen. Is it share screen? Does it
We are
can you see my slides?
Yes, sir. We are seeing the
Okay.
slides. You can. Yeah.
Okay. So, liver transplant for all HCCs or some, and if so, then when? That's what I've been asked to debate on. And the debate really is usually a single theme debate, but the title suggests that it is multi-theme debate. So is it some or is it for all? Should there be expansion of criteria? Should there be upfront liver transplant versus local regional therapy and systemic therapy first? Or are there any absolute contraindications such as pulmonary tumor thrombus and extrahepatic disease? The background, of course, is liver transplant for HCC is a very successful treatment with excellent long-term results. The Milan criteria is widely accepted and remains the standard selection criteria in DDLT. However, when the DDLT was framed, neither local regional therapy nor systemic therapy was there or was as effective. Therefore, in the present era, one can make a case for considering transplant as a treatment option for all HCCs. Now, before I actually begin this debate and talk about the transplant should be done all, I must actually also put in perspective what is our policy at our center. So we do not transplant for extrahepatic disease or those with portal tumor thrombus. Most HCCs are treated first by resection, local regional ablation therapy, systemic therapy, whenever liver function will permit. And liver transplant is not the choice even when there is underlying cirrhosis. All candidates for liver transplant will assess for neoadjuvant therapy, TACE, TARE, TKIs, or immunotherapy. Now, is portal vein tumor thrombus a contraindication? Till recently, this has been the case. However, large centers have now been extending the reach, and there have been 3 major publications on this, one from Korea, one from Choi, and by Soin, who've shown that reasonable survival rates can be obtained when there is segmental portal vein tumor thrombus combined with low biological markers. However, our own experience when we transplanted with portal vein tumor thrombus has not been as good because the median survival is only about 30 months as compared to without portal vein tumor thrombus when the survival is around 120 months. So the real difficulty is options when there is both the stage of cancers and the cirrhosis advance. And the options here are very limited. These are patients with high AFP, PIVKA values, the right and left portal vein tumor thrombus, the bad tumor biology, and obviously these are lesions which are beyond cure. Now, one interesting concept that I'd like to introduce here is many a time treatment by oncologists cannot be done because they worry that there may be decompensation post-treatment. For example, radiation-induced liver disease. And an interesting strategy we feel is that these patients should not be denied treatment for fear of decompensation, because if there is a willingness to go through living donor liver transplantation, then obviously if they had liver decompensation, then they could go through liver transplantation as long as they are being followed up closely. We've done this a few times, though we've yet to publish it. And more often than not, we're able to manage treatment-induced liver failure. And therefore, clearly, the management of HCC should be with the liver team rather than with the oncology team. Now, if you look at results of surgery for other GI cancers, for example, pancreatic cancer, cholangiocarcinoma, or gastric cancer, the average 5-year survival is less than 50%. So why judge liver transplantation for HCC with a different yardstick? Now, the theme, the buzzword in oncology is prolongation versus cure. The great majority of treatment cancer is prolongation. So would it be unfair to deny liver transplantation for HCC when we know that it can prolong life? For some, extra few months may be equally important. And I remember I had a young male who developed liver failure from alcohol, Hep B and Hep C with tumor thrombus, and he was keen to marry his girlfriend, complete his family, and leave behind an heir. And we went ahead and did the transplant. Of course, he died 2 years later. The Milan criteria is too restrictive because HCC is now one of the commonest indications for transplantation, and over 40% transplant in AMC, San Medical Center, is for HCC. Inevitably, then there will be pressure for living donor liver transplantation in those who are beyond the Milan criteria. The working committee in the ILT has suggested that for 60% 5-year survival should be the benchmark, and therefore large centers have framed their own criteria, led to the concept of metro ticket, that further you go, the greater is the recurrence, but yet still long-term cure is possible in some cases. So if you look at the summary of HCC criteria in Asian liver transplant centers, the maximum tumor size has been 8 centimeters, maximum nodule with 6, biological markers have been less, and when it's more than 10 centimeters, then liver biopsy and tumor grade has been used to guide transplant. Overall survival exceeded 70%. Now, what is the issue really in this debate? The issue really is donor issue. There is a small risk to the living donor. Short-term liver morbidity is universal. Cadaver donors are rare. So if there were no donor issues, I would have won this debate hands down. And should xenotransplantation become a reality, and there's a lot of progress in this debate would be meaningless. So really, we should be focusing on improving donor outcomes rather than considering who should be transplanted for HCC and who should not. So at our own center at CLBS, Milan always, we have over 5,000 transplants now, of which about 25% is HCC. Milan performed the best. UCSF was second best. But even in those who were beyond it, who had advanced HCC, 5-year survival was possible in a few patients. And prior local regional therapy had an important role. So we went on now to frame a policy where we do local regional therapy first. And we studied this and published this in JCA last year. We looked at two groups of patients, those who had local regional therapy first and those who underwent LDLT upfront. And these are patients who were actually within Milan. And if you stratify the results within Milan, within UCSF, beyond UCSF, Milan, of course, Milan and UCSF gave similar results. But what is interesting is in the patients who had local regional therapy first, had in all the categories had a overall trend towards higher survival, long-term survival, if they had local regional therapy first. But if the tumor was beyond UCSF, then the results were not good, suggesting, and this is in difference to what others have shown, the downstaging and bridging improves results, but actually the survival, even with local regional therapy, once it beyond UCSF was not comparable. Therefore, liver transplant for HCC gave good results. Milan was the best, and local regional therapy led towards better overall survival. And this is similar to what the Japanese Transplant Society has suggested, that if the recurrent rates are lower, 5 years overall survival is over 75% if you do local regional therapy first. And multimodality treatment of unresectable HCC or advanced HCC works well. This is a case who had TACE, SBRT, sorafenib in those days, and now, then later on went on to have transplant, and 12 years on, again, there's no evidence of resection. An important aspect of resection, which we often forget, we often look at resection as a curative treatment, but resection can be considered as a downstaging therapy as well in cirrhosis. There's somebody who had pulmonary tumor thrombus, we resected, and then went on to have a transplant and still alive. What about salvage versus primary liver transplantation? There's some confusion, but overall, the results are similar. So with the advent of neoadjuvant therapy, there are many reports that even advanced cases of tumors outside the liver can be downstage, and then obviously they can become candidates for transplantation. Therefore, in summary, indications have expanded. Liver transplant should be considered for great majority. Effective local regional therapy and systemic is now available. And we must remember that over 50% 5-year survival may be possible, which compares well with results of treatment for other cancers. And focus should be on donor safety, which is the key issue in this debate. Thank you very much for your attention.
Now we'll hear the other side of the discussion by Dr. Sudhindran from Amrita Institute, Kochi.
Just call you back.
What do you advance the slides? Please. Hi, thank you very much. Actually, I think it's unfair to say that we will not do liver transplantation for any at all. So I think in many ways, both of us are talking about the same thing. Actually, if you think about it, the first successful liver transplant in 1967 was actually done for an advanced HCC, and I think he went ahead and lived for almost a year. And out of the first 10, 4 were for HCCs and 1 for hepatoblastoma. And in those days, it was actually considered that transplant is the ideal solution for hepatocellular carcinoma because it not only takes the tumor completely with the maximum margins possible, but also cures the primary disease, which is whatever it is, and can be done in any sort of child B and C, etc. So people kept on doing a large number of transplants. Still, in the 1990s, it was plagued by recurrence. They realized that this is not a good option and actually became a contraindication for transplantation. So in those times, HCC was a contraindication for liver transplantation because almost everybody recurred. Till this gentleman, Vincenzo Mazzafero, he found out the reason for the recurrence. He found that it was actually microvascular invasion. Macrovascular invasion, yes, definitely, but microvascular invasion is equally important. The problem is that we cannot identify microvascular invasion even on a biopsy. So which was why this morphometric criteria came. So surrogate markers for microvascular invasion. The best ones were the size and the number. And as we know, this cardinal paper in 1996, where the Milan criteria was came in. And then subsequently, most people will actually go for UCS, which is what we also do. And we know that over the years, the priority given for HCC has actually changed in the US. So if you look at it, initially it was the morphometric criteria, that is just the pure UCSF. But even in that, some people actually did not do that well. Subsequently, they've added this tumor biology, predominantly alpha-fetoprotein, and response to downstaging. And finally, even the waiting time, because they found that the longer you wait on your waiting list, the better your prognosis. That does not mean that you should ask them to go, okay, you wait on the waiting list for 6 months, you'll get better. It is not because of that. So, and this results, I think, probably one of the good papers from the UNOS, where large number of transplants, 2,000, almost 2,200 transplants for HCC. And again, 95% of them were actually within the Milan, 2022, and some downstage to Milan, and very few that were not downstage at all. Some of them managed to get onto that list and get the liver. And if you look at the survival, significant difference, 61 versus 52 were the downstaged and 43. I think this is exactly what Subhash also showed. The ones were actually within the Milan, but I think he showed different things. That is the ones that are actually underwent the downstaging procedure did better. But here it's the other way around. The ones that actually downstaged, maybe they were outside the Milan criteria first, and then they were downstage to Milan criteria. And the 10-year recurrence. Everybody. And of course, obvious reason is the disparity in the gap, because we just do not have enough donors. Therefore, which is the reason why any DDLT predominant country, you cannot transplant somebody who is beyond the Milan criteria or UCSF criteria maximum. Sometimes it's up to 7. Even up to 7 is more or less like in UCSF criteria. So therefore, basically, the external criteria is going to be restricted only to living donor liver transplantation. That's unfair, isn't it? Why should there be a different criteria between DDLT and LDLT? I think it's purely a philosophical problem, because DDLT belongs to the society. And therefore, because that means society should decide, because the maximum benefit should be available with the limited number of livers possible. That means the people who get the liver should live the maximum. But on the other hand, So this is the utility principle compared to the living donor liver transplantation, where it is a private gift. And the donor is saying, I do not mind what happens to me. I just want him to live, even if it's a 1 year or 2 year. The so-called transplant benefit principle. This is again the case that Subhash could alluded to, the guy with hepatitis C. He just wanted to live 2 years to marry and have a kid. And obviously that's not possible with the DDLT, but at the living donor liver transplant, yes, that is possible. So the transplant benefit principle, if you do the transplantation, is going to be live a little bit longer, but not much, just a little bit longer compared to not doing the transplantation. And then, of course, the same thing, the double equipoise, the risk of the donor versus the recipient benefit. So our usual argument, yes, the recipient has got a huge benefit. The donor has got a very low risk. And so it is ethically acceptable. But then how do we decide the ethical acceptability? It's the individual pair. This again, one guy was transplanted with a margin, with a portal vein thrombus, branch portal vein thrombus, completes 10 years, without any problem. So they will say that that's fine, no problem. But the society, again, Subhash has said this, that is the ILTS society. They say that somebody should live for at least 60 years, 5 years survival should be at least 60% if you want to have a reasonable result. So that is what we should be aiming for. Now, is there risk of recurrence higher in LDLT compared to DDLT? There has been a lot of thoughts on that. And the reason they say is that because the living donor graft will regenerate. And when it regenerates, there is a lot of VEGF production. The VEGF will actually help in the angiogenesis. So even if there is a one small tumor cell left, the angiogenesis will come and help the tumor to divide rapidly. And it's also been shown that the smaller living donor graft compared to a small size graft, the recurrence is actually higher in a graft, which is actually a good graft. So same reason, because the VEGF factor will increase in a higher regeneration, leading to higher risk of recurrence. But this fast track in LDLT, that is the reason. If you wait for longer, why should there be a lesser recurrence? I think it's a very simple thing. Because same guy, within Milan, is actually listed for both DDLT and is planned for LDLT. By 2 months, the LDLT is done, but he hasn't got a donor yet, so he's still on the waiting list. Then at 6 months, he finds that there is actually a lesion in the liver. By this time, obviously, recurrence has happened to the LDLT, but from the DDLT, the reason it's not done, and is actually removed from the DDLT list. So therefore, we always have a test of time in DDLT, because the longer you wait, the ones who had recurrence or as one who had become bad prognosis, has gone out of the criteria, they are moved out. So eventually, the ones that have a transplant are always the good prognostic ones with a good biology, which does not happen in LDLT because it's always fast-tracked. So you're transplanting all comers. We don't know the ones with a good biology. So at the end of the day, I think biological markers should be very, very important criteria for deciding on transplantation. So it could be just a simple AFP, delta AFP, PIFCA, PET avidity, and downstream effectiveness, which is again what Subhash alluded to. And nowadays, I think genetic markers are going to come. I think eventually the genetic markers will probably play a good role in deciding that biology and who should be actually transplanted for HCC. Now, the absolute contraindication, Subhash also agreed with that, portal vein thrombus, hepatic vein thrombus, ruptured HCC and extrahepatic metastasis. But then even in those patients, this is the one from Soin where he was giving 1 year survival of 82% and 5 years survival of 57% for HCC with portal vein thrombus. We have not managed to get that result. If you've not done that many, I think only 3 or 4 have done. All of them recurred within 6 months. This is another paper again from Choi where they've got reasonable result. And our own state, I think Venugopal has published his paper, portal vein thrombus at 2 months following Atesbevo and transplantation. He's still alive. So if you want to talk to the patient, you can say that, yes, it is no more a complicated contraindication because it can be done and there are results. So counseling the family, I think it's not difficult at all. Because the potential donors, they're bent by emotions and overwhelming love for their recipients. And if it's altruistic donors, they're getting money, they're least bothered whether it's going to recur or not. And recipients, of course, they're going to go ahead with this because they want love. Even their spouse or the children, they're prepared for them to have a surgery because they want to live so much. Probably because they want to make sure that they're alive to make the family live more happier or better. Therefore, I think for us, it's very, very easy to push them for a transplantation. We can say, okay, this is there, the transplant has been done for these patients, and there is a chance that they can do well. So you give them a chance, they will always take it. But the honest counseling should include and tell them that there is going to be a high chance that if there is a portal vein thrombus, or if you're beyond this criteria, it is going to recur within 2 years. Are you prepared to face it at that particular stage? Imagine that situation. And if you're prepared to face that, you should go to the surgery. Otherwise, you should not. Because at the end of the day, it's always the donor who suffers. So he will do it. And when the tumor occurs, he will still blame it on himself. And then, he's lost his physically has lost, emotionally has lost, fiscally has lost. So I think we should be very, very, very careful when you transplant outside the criteria. Thank you.
The topic is open for discussion.
Subhash, the rebuttal will be there? I don't know.
Dr. Subhash, can you hear?
Yeah, I can. I think the point that I've been trying to make over the years is that living donor liver transplantation is an amazing treatment option. Unfortunately, we are tending to transplant more and more without using the various modalities that have now become available. Dr. Sudhi's mentioned that immunotherapy and transplantation. Similarly, we published a lot now where local regional therapy, even within Milan criteria, and then went on to transplant. And that is something that's really, I think, the discussion nowadays rather than transplanting upfront. So perhaps maybe that my friend Dr. Sudhindran can say a few words as well. I think strongly believe that the time has come that instead of offering transplant straight away, at least in LDLT, we can have a backup for a donor should they decompensate, but at least try all forms of treatment modalities before you actually suggest transplantation. That was the main point I was trying to make.
Yeah, Subhash, I couldn't agree with you more. It's exactly what we do now. Even if they're within the criteria, we downsize them, give them a time, like 2 or 3 months, and then you get a good time to assess the biology, and then go to the transplant.
That's what we agreed on then, 100%.
Both of debate.
Dr. Subhash, how do you manage your post-transplant recurrence? Would you like to give them monoclonal antibodies?
Yeah, it's the very important question you raised. And the post-transplant recurrence, I think first is follow-up, and which is that they all have AFP and PIVCA every month. Then they have MRI of the liver and HRCT chest every 3 months, or whenever the AFP PIVCA goes up. And actually, we manage successfully recurrences nowadays. Usually, usually we'll pick up a single lesion. Usually, it's a single lesion, which will either ablate or give some external beam radiotherapy. Occasionally, of course, we've had patients who've been on, particularly those who have extrahepatic recurrence, then lenvatinib works well. We've not used monoclonal antibodies for fear of rejection. In 2 patients, we used it who were many years post-transplantation. Gradually, we reduced the immunosuppressive doses, brought it to 0, and then went on to have immunotherapy. So recurrence post-transplant is not such a bad thing. We have quite a few patients now who are actually with the recurrence, but still going on. So that's the point I was trying to make, that, even if you sometimes if they have advanced cirrhosis and there is no treatment is possible, but if you transplant them, then follow them up, some of the recurrences you may be, if you pick them up aggressively, you may be able to manage them successfully.
Do you drop the immunosuppression significantly?
Yeah, we definitely reduce the tacrolimus dose. Though we're not a great fan of just everolimus alone, because rejection rates are high. So we'll usually just keep them on low dose tacrolimus.
Do you give lenvatinib post-transplantation as adjuvant
No,
at
we
all?
do not. No. I think it's not tolerated, number one. And so far, how long do you give it? I mean, if they're going to have recurrence, you give it for 6 months, then they'll have recurrence after 6 months. So really, and it's not benefited in some of the high-risk patients we've done, like that man I said who had 2 years. We had given him lenvatinib, but first, it had no benefit. He died from his disease 2 years post-transplant.
Okay.
There are no questions, I think.
Thank you, Subhash.
Thank you very much. Thank you. Pleasure.
That's Subhash and Dr.